patient we saw for foot pain. Alright, so we had a 55-year-old female elementary school teacher who we were seeing with a referral diagnosis of stress fracture into the metatarsals. Really her chief complaint was coming to us with this dorsal pain, the pain in their dorsal left foot. It has been present for about a year now, and really one of her major complaints was the fact that she was still walking with this boot and now currently using a cane as well. There was no injury, but the pain has been present for the past year. She had a photo score of 33 with a predicted level of change of 18 points to occur over 51 days and 13 visits. Her primary complaint in her left foot was an intermittent, superficial, and sharp pain which occurred through the medial part of her foot when stress was placed either through the tendon or specifically through the great toe. And now she recently also had developed some low back pain, which was most tender at L3, and it was generalized to the right side. She complained of a constant, deep, and aching low back pain, also rated as 6 out of 10. There was no numbness or tingling present at this time, and as far as the relationship goes, the back pain had developed since she had started walking a little differently with her walking boot. Some possible other areas or structures which could be a source of her symptoms. In her left foot, the first, second, and third MTP joints could all be possibilities, especially because she reported in her history of past of stress fractures. And also the tarsal and metatarsal joints are in that area. For her low back pain, the lumbar facets, the intervertebral joints, and the SI joint could all refer to that area. For her other structures which could refer in her foot could be the ankle, any ligaments of the dorsal foot, or bones in that area as well. And in her low back, sciatic nerve and hip could also be referral to the low back. Contractile structures in the foot could be specifically the extensor hallucis longus muscle or tendon, the extensor digitorum, the tibialis anterior, and all the foot intrinsics of that area. And in her back, the multifidus, erector spinae, glute max, quadratus lumborum, piriformis, and glute medium are all commonly referred to the low back as well. Another possible structures in the area of her medial foot could be the spring ligament, and in her low back, the trochanteric and ischiogluteal bursa. So our hypothesis prior to the interview at this time as a primary would be a stress fracture, because that is all we were given as a referral diagnosis, and then secondarily we could possibly be thinking maybe just a foot sprain. For aggravating and easing in her foot, the flexion or any kind of stress through the first ray really seemed to be the type of things that flared up or caused her pain specifically, and easing her pain would have been the unloading and kind of stabilizing that she got from the boot seemed to help. And in her low back, extension was definitely the worst, especially extension with right rotation, and that pain again was eased with any kind of flexion. Some more on her history. As far as sleeping goes, she really didn't have any problems sleeping through the night, and then throughout a normal day, the pain was normally minimal during the morning, but progressively got worse throughout her teaching day, especially when she was on her feet more. But she has been wearing this boot throughout the day, actually for the past 9 months, which seems to help a little bit. She's had the pain specifically in her foot for the past year, been in the boot for 9 months, due to the fact that she had this kind of insidious pain early on. She later developed a stress fracture into her third metatarsal, which was diagnosed through an MRI. She was then placed in the boot to protect that fracture, and she actually, a couple months later, developed another stress fracture into her second metatarsal. She continues to have a lot of the pain, actually now, into the dorsal part of her first toe or first metatarsal, while she has continued to wear the boot for the past 9 months. She has since developed low back pain since being placed in that boot and kind of compensating with an awkward gait, and she's added a cane to that now as well. She does have a past history of skin cancer and received a short episode of physical therapy for her low back pain, and was also given the walking boot to protect her left foot. The red flag screen was clear. She does have some yellow flags of fibromyalgia, RSD, and depression have all been diagnoses given to her in the past. The radiographs were all negative, but the both MRIs have shown stress fractures. That's on the second and third metatarsals in the past. She's now taking vitamin D supplementation as well as Prozac and Advil. Some of the more important signs we take from her history was, one, the fact that her symptoms are increasing when she's standing and putting pressure specifically through the medial portion of her foot, as well as that her symptoms are easing with rest. And as far as her back pain goes, that it kind of was produced or came about during her time when she was walking with the boot on. So our hypothesis kind of at this time may have kind of changed. Kind of thinking more, it looks more of like an extensor hallucis longus tendinosis, due to the fact that she was in a boot and her first toe or first ray really wouldn't have been at any kind of risk for it being in a position where it can develop another stress fracture because it's been protected. And then we also maybe think it could be a fibromyalgia or RSD type pain, specifically related to this patient. And we've kind of ruled out, again, like I said, the fact that I said the stress fracture is kind of ruled out because she's been protected over the past almost year. I guess the 9 months she's had that thing pretty well protected, and we've ruled out any neurovascular complications as well. The severity of the condition at this time I would consider as moderate, due to the fact that she has consistent pain and fairly low functioning, evidenced by a pretty low photo score of 33. I didn't think it was quite as severe because she is still able to do her job on a daily basis, but her pain and the discomfort that comes with it is something that she goes through consistently every single day. As far as irritability goes, though, I would consider that more severe because really, as far as tolerating any kind of flexion or movement at all of that first toe, she really doesn't tolerate it, and it's very hypersensitive at this time. And as far as activity to bring on her symptoms, it really doesn't take much at all. Any kind of weight bearing or movement, especially of that first toe, seems to bring on her symptoms, but again, they relieve fairly quickly with any kind of rest. So our hypothesis of what's causing her problem is that with the stress fractures that she sustained in her second and third metatarsals, she's kind of started to compensate by maintaining this dorsiflexed and almost extended position of keeping her first toe extended almost at all times, and she kind of weight bears through her lateral foot to avoid putting any pressure on that medial portion even while she's in the boot. So that's really kind of sensitized that extensor hallucis tendon, and while it's always maintained in that shortened state, and really just brought on a lot of inflammation to the area. The condition is becoming worse at this time, especially with the addition of the low back pain, and so I would consider her in the chronic inflammatory stage because this has been going on for almost a year now. And right now her symptoms are fairly consistent and they're reproduced really easily in an exam, and it's more of an inflammatory component due to the fact that she is maintaining that kind of that dorsiflex and extended position, which is bringing on the inflammation. So to help us rule in and rule out some of the other hypotheses, we still want to do some stress testing through that first ray if we are still having any kind of question of whether it could be a possible stress fracture. But overall palpation and range of motion testing, just to see if there's tender structures or overall range of motion through the foot and through the toes, will help us to form a better hypothesis. And as far as deferring, we might decide to, or we did decide to defer muscle testing, especially of her great toe, because she was really hypersensitive at this time and we didn't really want to make her condition any worse. some of the precautions we have for this patient is kind of her fibromyalgia and RSD conditions that she has, just to kind of keep it in mind and know that it's there. As far as her posture, like we said, we really noticed that she places a lot of weight through the lateral portion of her left foot in standing. Her functional movement, kind of the asterisk sign from there is the fact that she really cannot flex her great toe on her left side at all. We cleared the other surrounding structures, and we also found that she was a little hyperreactive as far as her reflexes, especially in her left Achilles. So as far as range of motion goes, through the first MTP joint, she had pretty much normal extension motion, but as far as flexion, we only had 5 degrees, which is pretty significantly reduced. And as far as her lumbar range of motion goes, she had full motion and flexion, but really only 30% in extension, which brought about pain as well as extension with rotation to each side. And during our palpation testing, we also found that her pain was reproduced when we placed the great toe in any kind of flexion, stretching that extensor hallucis tendon, and that pain was eased upon releasing the great toe, really, or putting it back into a neutral position. And also we could produce some of that past pain that she had in her other metatarsals when you just palpated the second and third metatarsals at all, really. That brought about quite a bit of pain as well. And in her low back, there was some tenderness to palpation at the L3 segment with PA testing. So we did find some hypermobility actually at L3 as well, with the segments above and below a little more hypomobile. She found weak plantar flexors, as well as her ankle inversion was weak, but all of her other ankle Manual tests were within normal limits, and great toe extension and flexion, as we said before, were deferred at this time. The extensor hallucis tendon was in a slight contracted position, kind of maintained in an extended position. And as far as motor control goes, she did have quite a bit of atrophy in her gastroc soleus due to the fact that she's been in a boot for the past 9 months and has not really had any way of working those muscles or using them on a regular basis. And her slump test was negative at this time as well. Our primary hypothesis at this time, following the physical exam, is really more of a tendinosis of the extensor hallucis longus tendon. There are contributing factors to this would be the past stress fractures in her surrounding metatarsals and the extensive time that she's been in her boot, which has also predisposed her for her current episode of low back pain and the weakness she has in her calf. Really the important asterisk signs we take from the historical portion of our exam be the fact that she told us how she walks, especially when in the boot, and even without it, how she's always got her weight shifted to the lateral part of her foot and keeping that big toe in an extended position. As far as the physical exam goes, we could really visually see that tendon as well, almost poking through the skin, and it just appeared to be very, very inflamed at that time. And she really would not tolerate any kind of flexion, putting stretch on that tendon without reproducing her current symptoms. So, as far as prognosis goes with this patient, we do expect to return to a fairly high level of function, almost to her previous level of function, whether we work on that through weight acceptance and moving out of the boot and allowing her to get rid of her cane and stabilize her gait. We expect this would take about 10 weeks, seeing the patient maybe 2 times a week initially, and eventually reducing that to more likely 1 time a week. As far as our patient goals that we have is she really wants to get out of the boot and get away from the cane and be able to return to a full day of work without really any kind of limitations or constant discomfort, really. And we'll know when she's ready for discharge at the time when she can tolerate really full weight bearing for almost maybe even a week's time without experiencing any kind of setback.